Hey guys, it's Hannah with the Weight Loss Collab, and today we're bringing you a very exciting conversation. Dr. Dovec had a chat with Dr. Josh Roller of Roller Weight Loss out in Fayetteville, Arkansas. They talked about so many great topics, including medications, medical tourism, why the ESG is maybe not the best choice, and how they're both laser focused on improving access to care, patient community, and just overall improving the bariatric surgery and weight loss landscape. So have a listen, let us know what you think, and we can't wait to see you next time.
Tell them where you are and a little bit about yourself, Josh, and what neck of the
All
woods
right.
are you coming live from?
Well, so I'm in Fayetteville, Arkansas, and grew up in Tulsa, Oklahoma. Then kind of went down to Dallas and over to Duke, and then ended up in Fayetteville. And I remember in my fellowship when they asked me, like, where are you going to go from Duke? You know, it's a big academic place. And I
Yeah.
said, well, I'm either going back to Oklahoma or Arkansas. And they looked at me and thought I had lost my mind. And they actually offered counseling. They said, "This, no, you can't do that." I was like, no, I got to get back. I got to get back home. I got to get back close to home. So Fayetteville's about an hour and 45 minutes away from my family in Tulsa. So it's been good. But yeah, we grew this. And my wife, Dr. Kristen Roller, and I had to beg her to work with me. And then she said yes. So beg her to marry me, beg her to work with me. And then, we started this practice like 18 years ago. In September, it'll be 18 years, which
Wow.
I know it does not seem like 18 years. It's gone by so fast. And it's been amazing. And when we first moved here, our big problem was that nobody covered weight loss surgery.
Mm.
Right? Nobody covered it. And I remember calling up Kristen and going, first week, like first 2 days, I found out Walmart didn't cover it. Tyson didn't cover it. Nobody covered it. And I said, Kristen, you need to stop unpacking. We're in trouble.
Oh,
And
wow.
so, luckily, there's a lot of patients around. We put together a very aggressive kind of self-pay, cash pay program, and then, we really worked with the insurance companies pretty hard, and just met roadblock after roadblock. I finally and then realized that they're not going to say yes.
Hmm.
Like they're not going to willingly cover this. So then I was fortunate enough to meet some people in these companies that have lots of employees, and they're really good to their employees, and they wanted to help them. And so I went that route. I just went straight to the employers and said, "This is what you got to do. Not only, is it going to help your employees with the diabetes and high blood pressure, heart disease, and cancer, all this stuff, but it's going to save you lots of money too, because you're not going to pay
Hmm.
all these medical bills forever." And they fortunately bought into that, and then it's just kind of grown. So that's kind of how we got on the map. And like today, I pre-opt 6 people. It was
Wow.
one from New York, one from Louisiana, one from Tennessee, 2 from Missouri, one from Arkansas.
Only one from your neck. Wow.
Yeah, and it's like and it's and I have 4 other partners that see lots of people. So we've been very very fortunate. It's been great, and you kind of had a similar experience where you kind of left a very known established thing to go to a very competitive market in Florida and start your thing from scratch. So not an easy thing to do.
Well, I appreciate that. I mean, truly, there was a conference, and actually, ironically, Allison just joined, and she was at that conference too. And there was about 8 of us total, and 7 of which were in private practice, and one was hospital employed. And I truly that was a pivotal moment for me in my career, was listening to everybody talk, and we all had these great ideas, and people were really learning and kind of feeding off of each other. And I realized I didn't have the autonomy to really run with my ideas. And
Yep.
you were the moderator of that conference, and you were really saying some things, and I left there, and I'm like, what am I doing? Like, what am I doing with my life? And I don't know if it was a midlife crisis or what, but I really think, like what you were saying, like what we both really want to do, and I think that the only way you can really get there is if you do have that control of having a vision and being
Right.
able to execute that, is to, like you said, get creative and go to the employers. I think what you did was absolutely brilliant, that you're from Oklahoma, you went to Duke, you're really well trained, you're an excellent surgeon. A lot of us are, but what you did was you took it to the next level and recognized that the largest employer in the United States of America wasn't covering weight loss surgery. And when we all talk about improving access to care, I really think that those who do the best job are people like you who go out there. It's uncomfortable. It's hard to get the right person in the room to have those conversations. But when you do, it really changes the game. And that's why we're doing what we're doing. And hopefully this
Yep.
conversation is going to be really helpful to a lot of people, where we're going to set a lot of records straight. We're both very opinionated. We're not going to hold anything back on what we think about some of these trends. And yeah, I'm super excited for this conversation and really some of the questions that we're going to probably get asked.
Yeah, me too. And it's one of those things that as long as you keep making decisions that's in the best interest of your patients, you're gonna go the right direction. I mean, every time. And okay, why isn't this covered? How do we get it covered? We know it works. We have all the studies that are there. We fight the fight every day. Fight the fight with insurance companies every day, and it is a tough, tough fight. And so I don't know. It's there's a lot of reward at the end of the day, which is funny. What I'm a very instant gratification person, and I think we picked the specialty that is like possibly the worst for instant gratification, because you have to wait a year to see your results, but you do it long enough, now everybody's coming through. So it's probably the most rewarding specialty I think you can do, and I, that's why it's not hard to go try to fight for your patients and try to get the coverage and just identify the roadblocks. And there are a lot in weight loss surgery.
Yeah, it's a grind. It's not easy. And you also, I just want to put this out there into the chat. If you guys have questions, comments, thoughts, we would love to see them. We're going to keep this interactive, so we're going to pull you in. We'll call your questions out. We want to hopefully get everything answered today. So we're going to, kind of get started with some of these things. But one of the big things I want to talk about is a surgery center. And a lot of people also, there's a lot of thoughts about doing these procedures in a surgery center safely. Obviously, that's always our top priority. But tell me a little bit about your journey to having this amazing office. You've expanded, like you said, you have multiple locations, multiple surgeons. You've been doing it for almost 2 decades. So what was kind of the idea of why did you decide to cross that divide and to start the surgery center aspect?
So it actually started with COVID. So when we got shut down and said, okay, you can't operate, when they finally, I think it was like 8 weeks later, they let us back in, but they said, the Department of Health here said, you can operate, you can do elective surgeries, which we can argue if this is elective or not, but they
Right.
classified as that. But everybody has to go home by 6 p.m.
Mm,
I thought, oh my gosh, this is going to be, we haven't done this. Everybody goes home the next morning, but you always worry about the nighttime and the witching hours. I thought, man, we're going to get a lot of phone calls. We got to be ready for this. So we really got prepared because patients were wanting it. Patients were scared to death of COVID. Is a very deadly if you were obese and suffered from obesity. So we did it, and then I realized we were getting less calls from patients. And they seemed to be a lot of our out of town patients we would see the next morning before they traveled a couple hours back. And they didn't look the same as they did in the hospital the next morning.
mm-hmm.
And we kept trying to figure out, like, what is the difference? And the difference was they were actually able to sleep and rest. And you start talking to a patient who got to go home, and you realize they didn't get woken up every hour. 2 in the morning for the staff in the hospital is like our 2 in the afternoon. They're
Yeah.
awake, they're talking, the lights are on. Rest. It's a place to get better. Hospitals have their place and they're good for that. But as a patient, you can't rest. Then you take a significant other, or the family or friend who's staying with the patient, who's sleeping in the recliner that folds out into, a brick bed, and they're not sleeping either.
Yeah.
So the next morning when they get to go home, they're both exhausted. But we're telling them, you gotta do your sipping, you got to do your walking, you got to do your deep breathing. And they're like, I can't keep my eyes open. You just literally, got up early the next morning and you just sleep deprived me.
Mm-hmm.
So that was when the light bulb went on that a surgery center or going home is safe.
Mm-hmm.
Going home works. We proved it then. So we started the planning and went through kind of multiple iterations of it. Got the 10,000 square feet back. That was a sleep lab and something like that from somebody who was renting. And we turned it into 4 ORs and 4 overnight rooms. So in case anybody needed to stay, those rooms look like hotel rooms, but they're outfitted like hospital rooms.
Huh.
So,
Okay.
with all the bells and whistles and things like that. But we've done now, I don't know, a couple, maybe 220 dual switches in the surgery center. And we had one person stay overnight, and that's it. And went home the next morning. Everybody else has gone home. They love it. They're happy. We think I personally think sleeping for them is everything for recovery.
Yes.
They're not exhausted, and so they can do what we're asking them to do. Which when you follow the rules and you do what we ask, it works really well. But I think we're asking patients back and that haven't slept to do things that they weren't physically able to do. So I think it's been great. I think it's the wave of the future. I think back when you were training and I was training, we kept people when I was a fellow at Duke for 2 nights.
Yeah. Oh, yeah.
So it seems like it takes a patient though, or patients to push us in the right direction. I remember when I switched from 2 nights to 1 night, I rounded on a lady the next afternoon. She was like 55 and she says, I'm going home. And I said, you're not going home. You're staying another night. And she said, Doctor, I'm going home. You can bless this or not. And I was like, well, man, she looks perfect. Everything's perfect. Okay. So I said, you have to call with anything. So I called her the next morning at 7 a.m. and she said, Doctor, I'm fine. I need you to leave me alone. I will see you in 2 weeks. And it just dawned on me. I was like, what? So why are we keeping people 2 nights in the hospital?
Yeah.
So then that's when I stopped keeping people 2 nights. And so then COVID pushed us into no nights. And, it's not, our techniques are so good now, laparoscopically and minimally invasive.
Mm-hmm.
Pain control is not the issue that it once was years ago. We know so much about preventing blood clots and preventing pneumonias and patients can do this at home. I mean, they can just do it at home. So why not recover in a normal type atmosphere? Even for out of town patients, they stay in a hotel that night, and it's still way better than not getting to sleep.
That's what I say. I give them a little cocktail, take your Gas X, your Tylenol, and oxycodone that first night, knock it out, just sleep. And also, I think that, when you're all in alignment with the goals, like if you're a nurse, it's almost like, all right, well, my job is to get them to the next unit. But if this is the case, you got to get them home. You're going to be a little bit more proactive in making sure that you're not giving them those sedating agents and you're getting them moving. And everybody's expectations are set that you're leaving. Like there's no safety net. Like you have to go home or, get going to the hotel, like you said, for your out of town. So anyway, I think that I do think that COVID, same for me. It really like changed my thinking. It seemed nuts at first. I surveyed all of my patients on our Facebook support group. And I said, how many of you who've already had surgery think that you could go home same day? And I got a couple hundred responses. And 100% of them said, no, there's no way I could do it. So
Right.
I was like, can't do it. But then you realize they can, because it's all about expectations. It's about really refining what you're educating them with and making sure that they can communicate with you as well. And I think when you get those pieces in place, you've proven it, I've proven it, that you can definitely safely do this. And when it comes to costs, that's another big thing. Like you said, you've always kind of had this competitive self-pay package, which is why you really draw people from all over the country and
Yeah.
world
Yeah.
to your center, which is beautiful. But I think the other big thing is in cost is in the way that you do the technique. You said, we're getting efficient, we're getting really good at it. And I think a lot of people, there's a lot of kind of conversation around the way in which you do it. So a lot of people know you just said laparoscopic, and there's also robotic techniques. And,
Right.
obviously I know kind of how you think about this, but I just really want to set the record straight out there for patients. What do you think about the differences, especially as it pertains to improving this access or availability of care to all those who need it?
So, I mean, the first thing is that a surgery center is going to be less cost to the patient. So just take gallbladder surgery. If you
Mhm.
have it in a hospital, it costs more. The insurance is, the allowables are higher. Your patient's going to get charged more by the hospital. The doctor gets the same whether it's a surgery center or a hospital. So nothing changes there. It's the hospital gets more. So if you have it in a surgery center, it's going to be more affordable just from the insurance standpoint. Now, most robots are in the hospital,
Mhm.
and that's because they usually cost like $2 million.
Yeah.
Now, I think the robotic technique and laparoscopic technique are really the exact same thing.
Mhm.
Small incisions, they're all minimally invasive. Um, and if somebody's more comfortable using the robot, then fine. I just, I think we're more efficient and better laparoscopically. I can tell you that our incisions are smaller
Mhm.
laparoscopically than the robot incisions. And I can tell you the surgeries are faster,
Mhm.
which means less time under anesthesia, less nausea, and a faster recovery.
Mhm.
Um, so, and you can do these in the surgery center. And to my knowledge, there's very few robots in a surgery center. And so, as these insurance companies and everybody's pushing towards value-based care and decreasing costs, you can do it in the surgery center, but you can't do it with, you generally speaking, a robot in there. Now, there's lots of other robots that are coming onto the market,
Mhm.
and I think they're going to get better priced down the road. And they have their spot. I don't think, I think doing a robotic prostatectomy, I think that's the perfect instrument for having your prostate out. That's how I would want mine done.
Mhm.
Um, Very small, in the pelvis, small area, sewing. But for kind of what we're doing in bariatric surgery, I think it's the equivalent of taking a bazooka to an anthill.
Yeah.
It's overkill. So all of my partners, even the ones that kind of robotically trained, we've transitioned to laparoscopic because it makes it more affordable for the patient, and the results are the exact same.
Mhm.
And I think it's all just comes down to the surgeon
Mhm.
and what they're capable of doing. So, but that's why it's just in our hands where we do it really well. And we use the robot for other procedures
Mhm.
in general surgery where it's necessary. Younger people tend to like it. I can't even believe I'm going to call myself old, but,
When did this
sitting at,
happen?
I just turned 50, so I'm
Oh,
there.
wow.
But it's not the future in healthcare, in surgery, is going to be about making things more affordable, which
Mhm.
makes it more accessible. And obesity is a disease that affects 2/3 of the country, so we have to make it better and easier for patients to get to it.
Mhm. Yeah, and I know we both agree we're obviously bariatric surgeons, but we feel as though bariatric surgery is the best. So I really want to dive into one of the hottest, spiciest topics that we're going to be chatting about today. And that is, and I want everybody to go into this comments and really tell us your thoughts about what do you think? Weight loss medications, all the hype. What is the deal with the hype versus surgery? And do meds have their place? Where do they have their place? Is it just surgery? Is it not? Like how do you decide for a patient? We get this question all the time.
Yeah, and it's a good question. There's a lot of hype, and everybody's always searching for maybe from what they think is a cheaper or faster or safer way of losing weight. And I get that. That's human nature. But our goal in surgery is to get people off of medicines and not to condemn them to a medicine for the rest of their life. And when you start a GLP-1, you have to continue it forever. The moment you stop it, the weight's coming back. Maybe there's an exception here too, but not really. I mean, almost everybody regains their weight. If I stop my high blood pressure medicine, my high blood pressure is going to come back. So that's what the medicine is meant for. The weight loss is also less. So take somebody who weighs 400 pounds, you can expect if the 20% that they would lose on the medicine gets them down to 320. Is 320 better than 400? Yes. Is it good? No, it's not good. So our goal in surgery is to get it really good. We want you to lose all the weight. And even more importantly, we want you to keep it off. I tell my patients all the time, I don't care how much weight you've lost at 6 months. I want to know how much you've lost at 6 years. That is our goal. That is why we do it. And a lot of insurances aren't covering it now. So now you're looking at the financial aspect, $1,000 a month, 12 months a year. Let's say you're 30 years old and you got to be on it for 34 years. You're looking at like $480,000. You could buy a really nice house with that.
Yeah.
Or you could have surgery like 25 times.
Yeah.
So, and that's the thing. Surgery is a tool that lasts forever. So that's kind of been our new push is, one outpatient surgery or 52 shots a year forever. And that is where we want. So I like the medicines in people who need to lose 20 to 30 pounds, maybe a little bit more, but it's, you just have to have and this is what I don't think doctors are having this conversation with them that you have to take this forever. If you don't take this forever, the weight's going to come back. And people don't realize the financial obligations that they are signing up for or the side effect profile. It's very real. We see it all the time. I've seen many, many people who've had emergency surgery from it. Stomach's not working. The nausea vomiting continues forever. And now we've seen them enough that almost all of our patients that come in have tried them. And it's either it didn't work, it cost too much, they worked, but I had to get off of it because of side effects, and now the weight's back. My insurance stopped covering it. There's so many things. And so if we want to try to get you off of the medicines, then weight loss surgery is the way to go. If you are interested in taking a medicine forever, then you should try the medicine. But that's not what we really preach in weight loss surgery.
We're getting a lot in the chat about this, a lot of good perspective. And, I just want to comment on some of it. So first off, Jessica, she's somebody that we recently had on our podcast. I know you have a podcast as well, and we try to bring on patients as guests in the different parts of the journey. So she's at the most magical part. She just had her 1-year follow-up. She is in the honeymoon. She's feeling it. She actually just had, she's very outward with this. She's Beyond Loose Skin on Instagram, and she just had body contouring. She looks incredible. But when she was on our podcast, she writes here in the chat, surgeries permanent, medications are conditional. She describes a time back several years ago before GLP-1s, but this was in the kind of the era of, she was doing something like phentermine or something, and it was like the Sudafed component, and she was at the store, and she was like, found herself like desperate that they were going to really lock down on it, and she was buying like boxes and boxes, and she just like kind of almost like came to two, like, I am so like obsessed. This is all consuming, like you're describing. They might give you coverage, take it away. You might be able to afford it, you might not. You start it, you have to stop it. There's just so many things that it's hard to really, I think, for anyone, like you're talking about the entire financial burden of this, to be able to stay on it for long term. Somebody else writes, Daryl says, I was on the meds, I lost 40 and I gained 57 back. I mean, how often do we hear that patients, you do
That's
well,
right.
and then it happens so much faster. Why do you feel like that it's the boomerang is even worse than if they've never been on it at all?
Well, I think you've blocked the hormones, right? And you stopped them, and then all of a sudden you release the floodgates,
Mm-hmm.
And I think they're even hungrier. And I think metabolism is even slower. I think everything that was being stopped. And that would be the one thing I would say is like, if you start really getting after hormones in our body and start blocking things and
Mm-hmm.
two of them or three of them, our bodies are remarkable. They're going to adapt and
Mm-hmm.
they're going to figure a way around it at some point. And, I would just caution everybody. I mean, Fen was a great weight loss drug back in the day.
Yeah.
And then it wasn't until everybody started having their, open heart surgery that it got pulled from the market. So I'm not saying that these medicines are like that. I'm just saying you just have to go in with an open mind and know, like, I just think doctors need to do a better job of disclosing to their patients this is forever. There are side effects. It does cost a lot if your insurance doesn't cover it. Um, and if you stop it, it's coming back. And so there's a lot of stuff you see on Instagram and social media about micro dosing and
Mm-hmm.
all of this. I don't know. I think it's gobbledygook. I mean, there's no one knows how to come off of it.
Yeah.
There's no consensus about how to do it. And I just think if you stop it, it's you're in trouble. You're going to gain the weight back. So especially in our patients, the
Mm-hmm.
BMI of 35 and higher, we need to lose
Yes.
60,
Yes.
70 or more pounds overweight. Then surgery is absolutely the way to go. And there is a question about doing the meds after the surgery. And I just tell people, we get this a lot in our support group.
Yeah.
I'd rather you come back in and work with our team and our dietitians to figure out, okay, if you haven't lost the weight you wanted to, or you're starting to put some back on, you still have the tool in place. So let's figure out what's not going right.
Mm-hmm.
And a lot of times people don't want to come back in, but when you're open and honest and you meet with the dietitians, let's say, and they can identify in a food journal, like, oh, you're doing this. And the patient goes, oh my gosh, we're not supposed to do that. Like maybe they forgot, maybe they didn't know.
Mm-hmm.
And it's an easy fix. So I don't necessarily rush to putting people on the medicines afterwards, but when we talk about it, we have the same speech. If we do this, it's forever. There's not a great way of coming off. And so, as somebody says lifestyle change, whether it's surgery, whether it's well, here's what I would say. Another big difference with the medicines, the muscle loss and the bone loss is very, very real. And there are now some studies out there that said up to 40% of the weight loss is muscle and bone. And you've probably seen all the stuff where it says you just need to be sure you eat all your protein so that doesn't happen. The problem is the medicines keep you from wanting to eat. So surgery doesn't keep you from wanting to eat. Surgery makes you feel full faster.
Mm-hmm.
And there's a huge difference between like, okay, I get full after 4 ounces of chicken versus I don't ever even, and I'm talking, beyond the first couple of weeks. Sometimes people aren't hungry right after weight loss surgery, but
Yeah.
down the road between looking at the chicken going, I don't want that. I don't want that. I don't want anything. And so what do we call it in medicine when somebody just doesn't eat?
Mm.
Anorexia.
Mm-hmm.
So is it chemically induced now? I mean, I don't know. I just like the fact that you can get your protein in with surgery. You need to focus on it, get it in first, and then you can go, all right, I'm full, I'm going to stop eating. So it reduces how much you eat, so you don't get as many calories in, then you don't absorb as many of the calories. So it works by multiple mechanisms, but not just by keeping you from eating. I think that's the wrong approach to weight loss.
Mm-hmm. Oh, yeah. Yeah, I tell patients all the time, like, especially when they first come in, they're like, what changes should we make? Like, I'm all in, I'm ready for this. And the biggest thing I say first, just make sure you're eating enough. Like, are you skipping meals? And I do think that that is one of the biggest detriments you could do to yourself because it sets you up for wanting to snack later and all that kind of stuff. I do think that you're right. I think when it comes to a patient who qualifies based on, these somewhat arbitrary BMI guidelines, we could talk about that all day too. But when it
Yeah.
comes to somebody who does qualify for bariatric surgery and does have that excess weight to lose, I mean, to me, it's like, oh gosh, stop prolonging the inevitable. I do think a lot of people do
Yeah.
feel like you hear this all the time too. Like, I just want to make sure I tried my hardest. Like, if that's the miracle thing out there, well, I just want to make sure I just gave it every single ounce that I
Yeah.
could,
Yeah.
including that. And so sometimes, like, I get it mentally, like, no matter what we say about here's the evidence, here's what's best for you. You want to try it, you'll do it. And I do think that there's no shame whatsoever in saying, like, some people writing in the chat, like, the miracle drug didn't work for me. Like, that wasn't maybe my reason why I'm overweight. It's not my GLP-1, or it's not, I've
Right.
already was eating too little, like you said. So, I think that's the key thing is that your program, I can tell, our program, we're not going to meet you with shame. We want to help you. We
Right.
want to help to evaluate and educate and make sure that you're doing these things, according to our guidelines. For the most part, you slip, you don't slide, and we are here to help you. But I do think that, like you said, the properly kind of counseled patient, especially people are asking about follow-up post-op patients. I do think that if there is a stall or even weight gain after bariatric surgery, the medications can be quite helpful in that population.
Yeah.
And really, like you're talking about the microdosing and this really low dose, a lot of times they are more sensitive to it. And so you don't want to build up this tolerance. And if you're seeing results and you're not having side effects and it's very low dose, sometimes we really are proponents of that. But like you said, understanding, people ask, so when can I stop? Or how can I, like, once I hit my goal weight, how do I kind of pace back off? It's like, well, you're probably going to see things start to creep up and you're going to want to, like, lean in again.
Yeah, I mean it's just like high blood pressure. The indication for the medicine is the exact same. It is indicated for the chronic condition of obesity. So if I stop my medicine, my high blood pressure comes back.
Mm-hmm.
Bottom, but yeah. And then I will say there are probably some stuff coming out now that's saying for the people that have stopped it and then are restarting it, that the results aren't also as good as the first time. So it's
Mm-hmm.
literally we just need to be. I think the doctor population needs to start being much more transparent about how
Yeah.
these things really work, and um, it's just one of those things, and that's how we feel about it. I think it's going to come around where we see everybody has tried it and like, okay, now I want
I do
something new.
too. I think that's starting to happen. Like, I'm starting to see, it's like, woo, our, numbers kind of go
Right.
down, and then you're starting to see people like, you know what, I tried it, and for all the reasons we just described, it's not happening. There is another question in the chat, interestingly, about the pre-op patients. Someone that's like, yes, I'm truly engaged to have bariatric surgery. And let's say they have on the higher end of BMI. Let's say their BMI is 60, 70, 80. They're 4, 5, 6, 700 pounds. I'm curious what you do. Do you ever start a medication before surgery, or do you do it through dietary counseling alone?
Mostly, I mean, we'll start operating at 650 and lower. 650, I think, is the biggest one or the highest weight I have done. We have some probably coming up. So I guess it depends. I mean, if somebody's 800 pounds and you're asking them to lose 150 pounds, it just doesn't seem like that's going to work. And so, although we've had guys, patients that have just nailed it, knocked out 60 pounds in
I
two
know.
months, and you're like,
Yep.
so I generally don't like starting this. Way back in the day, we used to do balloons kind of in them to lose some weight and then do the surgery. But, that's an expensive route too to
Mm-hmm.
get there. So we just have some awesome dietitians and, awesome providers. Dr. Chris and our team do a good job. So I think what we do is we give them a reasonable plan. We generally do like 2 protein shakes and a reasonable dinner, and tell them we got to get this weight off to try to get you down there, and
Mm-hmm.
then work with our team and the tools. And if they're motivated, you can see them do it in the short term.
Mm-hmm.
We know that if that's all, and so that's something you'll have come up, right? Oh my gosh, I just lost 60 pounds. What if I just kept doing this forever?
Mm-hmm.
Well,
Yes.
your body will catch up to you and it won't work forever. And you got
Yeah.
there by doing a liquid diet.
Yeah.
So just like the medicines, if you stop your liquid diet, the weight's going to come back. So that's the perfect time. Be motivated for those 2 to 3 months. Get that weight off, and then we operate. We do
Mm-hmm.
think it's safer. it kind of depends on body habitus too, like how you're shaped. And so on, like, we've done BMIs in the 90s,
Mm-hmm.
but most of their weight was lower in the
Yep.
legs and not in the abdomen. So you can do that easier. And sometimes males with a BMI of 40 can be super hard.
Totally.
So we work, it's all individual. So we haven't necessarily gone there on the pre-op side yet to use the medicines for that reason, but I'm not totally against it. We haven't had to use it yet.
Same here. We really don't go there either. And it kind of like when they're in, like you said, they might lose a pound a day. And it's like, all right, here we go. Now somebody else asked us an interesting one, and I really want to get edgy with this one. They said, what about this new endoscopic sleeve gastroplasty?
I
What
knew
about
I
the
knew you
ESG?
I knew you saw that one.
I did. I was like, oh, thank you.
All right, well, what do you think about it?
I mean, I think it's the biggest scam in weight loss right now.
I agree.
It
I
is
agree.
an absolute scam. And I'll tell you, the flashy commercials, the cartoons, the animations, on paper, it seems great. I mean, it's, no incisions, it's minimally invasive. We go in and we can just whip a couple stitches and you're going to do great. You're going to lose weight. I promise. I promise. Look at all these incredible results. Now, I have had people who, this always like makes me a little emotional when you think about how hard, first off, it's not just this, but how hard people have tried and they've paid their hard-earned money and they've saved up and they
Yep.
get funding or whatever. Like, you know how it is sometimes where it's like, oh, my parents loaned me money, or I've been putting this away, I've been financing this. And you really put your trust in this thing because it's
Mhm.
always self-pay. It's not recognized to be effective by the insurance companies. And so for that, you're spending 10 plus $1,000 typically on this flashy, minimally invasive procedure. And then they don't have results because to me, it's essentially a placebo. And then they come back to you, and then their spouse or their friend or whoever kind of supported them the first time is now like skeptical, like, are you sure you want to
Right.
do something else?
Yep.
And that, am I going to help you with this? And that's heartbreaking for someone to sit there like doing this walk of shame, like
Yeah.
they're the problem. When in reality, that it was not as advertised. And truly, when I get in there surgically, and I can't wait to hear, I'm sure you've revised some of these. You get in there and it is truly crickets. There is nothing in the abdomen that even gives you any kind of indication that there was this procedure. You scope them, I don't see anything, nothing. Or like a rogue
Yeah.
stitch over on the greater curve. Like, what's that doing there?
Yeah. So I've seen a couple things with this. Number one, I agree with you. It does not work. It has been applied to other um, procedures, like for reflux surgery, where it didn't really work, where you get in there and there's nothing there. So they've tried this before over and over again. And I think it's a lot like the lap band, where it
Mm-hmm.
just isn't a good surgery. And so just because you failed one thing does not mean you're doomed forever. It means that maybe you just didn't get the right surgery. And
Yeah.
so now you got this endoscopic sleeve gastrectomy. And we have had, so like you said, I've gone in there and there's like no evidence that anything's been done.
Yeah.
But the worst one I saw was a lady. We've had multiple patients that have done it multiple times,
Oh.
so more than once.
Oh, wow.
Coming from some major, uh, like major medical centers where it was
Yeah.
done, like centers that everybody would know. And on a couple of them, I got in there, and it was so deformed and messed up that I really couldn't do much to the stomach because the it was like just crazy looking.
Mm.
So I couldn't even. I don't know if it's because it's done twice. I don't know if it's done bad. It was not the way though the videos and the drawings suggest it should be. So it was. So I ended up just doing a dual switch and doing the other part, but I couldn't do much to the sleeve because it was like really narrow there in the middle and then wide. It was a mess. And
Mm-hmm.
I, there it's not a good procedure. We don't offer that. and it's not something we would recommend to patients.
Mm-hmm.
But they,
Yeah,
just like with the, I don't know, you may be too young, but with the lab band, they used to market it as
I know.
safer, reversible, no stapling of your stomach, all of these things. But at the end of the day, 51% of patients have to have their bands removed because of complications 12 years later. So in my mind, it ended up kind of being the most unsafe, but it
Mm-hmm.
was marketable because it was a device. And so anytime a band went in, somebody made money.
Mm-hmm.
I just, I've not seen the results. Most of what I've seen is just like you. It looks like nothing's been done, and then the patient thinks they failed,
Mm-hmm. Mm-hmm.
and they haven't. It wasn't a good procedure. So
Yeah. I
it
mean,
is hard. It is
it
sad.
it is sad. It is heartbreaking. Um, and that takes me to, almost this feeling of desperation. I mean, people come a lot. They want you to give them hope. They want to believe you. They want to believe that this will work this time. And that's the thing that, like, gosh, somebody gave their trust to this and you're like, but I swear, trust me and like, trust you. Like, I swear we are honest and we are leading you in the
Right.
right direction. And that kind of takes me to medical tourism. And I know, you've dealt with this a lot. People just, again, want something that they can afford and go for it. What are your thoughts about, going across the border and having these procedures done?
I know why people do it. I mean, it costs, you know, $6,000 or $7,000 versus 16 or 17 or 18 here. But there's a reason why
Mm-hmm.
it costs so little. And it, like in my office, if I have a whole army of people to deal with insurance, and we have 5 dietitians, and we have all these medical assistants and nurses and nurse practitioners and physician assistants to take care of the patients in the long term.
Mm-hmm.
And we know that long term follow up is better for patients. We know that. I mean, there's no argument there. So if all you're doing is the surgery and never seeing the doctor again, like if you and I did that, we wouldn't need 2/3 of our staff.
Mm-hmm. Yeah.
So there's more to the surgery than just getting this. So that's how we used to do it in the United States 20, 30 years ago.
Right.
30 years ago, I should say now. Because they treated it like having gastric bypass or surgery was like having your gallbladder out. You would do it, say, check your incisions 2 weeks later, and go, okay, you're fine. Good luck.
Mm-hmm.
It didn't work. Like patients didn't have the knowledge or the know-how to make their tool work. So that's what they're doing down there. And they're getting no follow-up. Then when they have problems, they come here. Our insurance companies don't like, or medical malpractice don't like us dealing with patients who went down there. My famous line is, I don't know if it's famous, but the line I use a lot is, if you can't drink the water down there, why would you have surgery down there?
Mm. Ooh, that's good.
What about a blood transfusion? And they'll tell you how it's safe and this and that, but I mean, we've seen some things, and things like that can also happen in the U.S. But the fact of the matter is, we're accredited centers are
Yeah.
regulated, and it's safer. But there's a reason why it costs more here. You know what you're getting for the most part
Oh,
if
yeah.
you find a reputable surgeon and accredited center. So I, and they're going to do the quickest, fastest, easiest surgery too, with the
Mm-hmm.
most profit margin.
Yeah.
Follow up, I would say the most reason, like we can do in the United States, even if somebody comes from New York, we'll still do their follow up care by telephone for the next year. So yes, it's further away than Mexico is for me, but we're still going to take care of that patient, forever. And I don't think that happens when people go elsewhere, out of the country.
I mean, I think no doubt about it. I think, like you said, they'll pick a procedure that 9 times out of 10, it seems at this point, it's always the sleeve, or even more than that. And I
Yeah.
do also have theories that they'll do a sleeve and they'll do it really, really big. because they kind of want you just to get back on that plane and get the hell out of there and honestly just be able to drink your water. Like, okay, I feel pretty good. No one wants to be dry heaving. No one would come down. So they make
Right.
it bigger. They don't properly dissect it. And then, all right, you got through the early couple days, but then you don't have you don't have restriction. It's not the best surgery for you. There's a whole host of issues that can happen with that, I think, as well. And I think another big thing about just starting, my own surgery center and with what you've seen, yes, I always knew about like sterile processing and that there's, clearly the sequence of events on how to get your instruments sterilized and all, like you said, the mandates and inspections, and
Right.
you know what you're getting with it. But what I think I knew it, but I didn't think I realized that you have to build like 700 policies and procedures about exactly how you're going to do every little nuanced thing. And one of my patients came back and they said, man, I saw them take a hose, a little garden hose, and spray down an OR table and then just wipe it off. And it's like, all right, you're up. And it was just like, well, I guess I'm in already. And it was just like a frightening thing. So anyway, just thinking about the checks and balances we need to do versus that, like, you don't know what you're going to get.
Yeah, I mean, there's a lot of things I would change about how things are done here in the United States, but I'd rather have it over too much bureaucracy than not any. And
Yeah.
just for the sake of just having somebody you can pick up the phone and talk to and call, that's why I like people staying here and around. Or if I have a patient from Florida and they're having an issue, there's plenty of surgeons in Florida. If someone from
Yeah.
Florida had issue, my patient was one of your patients is up here in Arkansas, you can handle that. But it's a bad situation when something goes wrong
Mm-hmm.
down there. There's no recourse for the patient, in my opinion.
Yeah. No, you're right. I think that the acute follow-up and then the long-term follow-up. And I know that you guys do a lot of things with your program. You had an incredible event that you do, it seems, at least annually. That's this red carpet, walk the runway. We used to do those as well. Fun and amazing. Tell
Yeah.
me a little bit more about the roller weight loss community and just some of the things that you guys do for your patients, which makes them want to fly down from New York and to have their surgery with you to be part of this family.
Our practice has gotten big, but we've tried to always keep it very personable. And
Mm-hmm.
you're going to see Dr. Kristen, you're going to see myself, one of my partners. We're highly invested in our patients. Word of mouth is how we get most of our patients.
Mm-hmm.
We do a lot on social media and things like that, but it's really word of mouth that drives most of it. Because there's nothing like if you see somebody that goes from 500 pounds to 200 pounds, you're going to ask questions.
Mm-hmm.
And so, there's always, we call it the aha moment, right? Where somebody finally decides that I'm having surgery. Like they went to Silver Dollar City, they got on the roller coaster and it didn't close and they had to get
Mm-hmm.
off and take their kid with them. Or they went to the restaurant and the booth didn't, slide back, or the air belt or the airplane extender. So one of the things that we kind of figured out was, so we do something called the red carpet event every year. This year it's in September. And now it's grown, so we've rented out the Fayetteville Town Center, this big 10,000 square foot area,
Wow.
big stage and the lights and all the stuff. And then, we raised some good money with that. People buy tickets. We donated, I think, about 12,000 to the Northwest Arkansas Children's Shelter last year.
Oh, that's awesome.
But the reason it's a celebration of our patient success. That's number one. And when we first did it, we did it in our office, like in the afternoon, and I was like, no one's going to show up. We're dressed up, and a lot of people showed up and they loved it. And the very next day they were talking about this has to be bigger.
Mm-hmm.
But one of the things that came from it was a lot of our patients never went to anything, fancy. They never put on the sparkly dress. They didn't go to prom. They didn't go to homecoming. They didn't go to formals in college. And they missed out on a lot. And that's what at the end of the day, that's what obesity does. It literally robs you of your freedom and your happiness, and just living life. And so we went bigger. I thought, oh my gosh, this is too big. No one's going to show up. And it was, we had 500 people there. And It was awesome. So every year it's got, I think this is going to be our 6th or 7th year. I can't remember to do it. And it just kind of keeps getting bigger, and patients come, and we usually have 30 patients walk the runway and a little 2 or 3 minute clip of their story and how they did it. And it's always just really interesting how everybody had their aha moment and how they got to us and to surgery. And the lady today of small town Tennessee, you
Mm.
know just I had operated on somebody in her family, and so that's why she drove to Arkansas. So it's a beautiful area. We love it up here. Um, and it's, I think the advantage, like coming to see us versus like going to New Orleans or Chicago or,
Yeah.
these big places, are a lot of people don't really want to get into these giant metropolises where you don't even know where to go.
Right.
Everything's so big and confusing. And so, we're pretty big area for Arkansas, but we're not that big, and so it's been fun. But that's kind of the vibe that we try to get at our practice, is that we want patients to feel very, very safe, very comfortable. Just like you, I'm sure you have the exercise wide chairs and the heavy tables. Like, no one's going to break a chair in our place.
No.
It's a place you can go and not have to worry about being judged. We're there to get you better.
Mm-hmm.
That's it. We're just going to get you better. And so,
Yeah.
however you got there, it doesn't matter. It's where we go from the point you come in. And so, it's awesome. It's a fun thing. I know that it's a lot of fun to watch the before and afters.
Absolutely. And I think that that's kind of what I wanted to just, talk a little bit about when you're looking at, people really research. And there's some of you on here right now. Somebody actually put a comment on our on the post that we did announcing this tonight, that they were coming all the way down from Kansas, and they were going to have their consult, and on their drive back home they were going to be listening to this Instagram live, and they felt that it was worthy to go there and to be part of it. And I think that there are a lot of countless tremendous surgeons and programs and great things all across this country. And I do think there's something special. I've been on both sides of being employed, and then also just owning it. And just like I said earlier, just the things you can do, like you can put this event on and all of that. And I think that you'll just get better care. Like, I do. I think in the end of the day, you do have relationships. These people become family, and that's why they tell their families about you and about what it is, and that you're going to be an honest guy that's from Oklahoma. That's just, you're just going to tell them straight, like what they need and why they need it. And I think that, the countless surgeries that you do speak for itself.
Right. I do think that as being private practice and independent of being owned by a hospital, that does give us a distinct advantage. It gives our patients a distinct advantage because, like you found out now, with your practice, when you want to do something and you think it's going to be a great idea, you just do it.
Yes. Have
The
idea,
road,
do idea.
yeah, the roadblocks are removed, and you're not going through a bunch of hospital administrators to tell you all the reasons why you can't do something.
Mm-hmm.
It's and the answer, I always call it the slow no. They never want to say yes, but now
Yeah.
you're in charge and you get to do it. And you make it's a business too, and you make a lot of mistakes as you're going through it. And so but who doesn't? And so it's fine. You learn from it, you move on, and you do it better. I mean, our practice looks nothing like it did when we first started. There was 5 of us. It was
Mm.
Kristen, myself, a nurse, an office manager, and a receptionist. And then I should say 5.5, our part-time dietitian, Anne, who is still with us to this day. So, it's been quite a journey, because now there's a lot of us and lots of great surgeons. I mean, that's the thing, you brought on a partner, and
Yeah.
then, you get into expanding into like the plastics and aesthetics, and, it's an interesting story of how we got into that. Um, what I realized, I was ignorant in the beginning about
Mm.
loose skin. I always tell people, well, loose skin never killed anybody. which is true. It does not kill anybody. It's not a reason not to have surgery. But what happens is when you have diabetes, high blood pressure in your back and your knees and your hips hurt and you can't move and you can't get up, that's what you're focused on. Then when that goes away and you've lost the weight, it's not like nothing else comes in. There's always something that's going to come in. We're always forever going to have problems. It's going to be different problems. And so one day I operate on somebody who we see every day, and it was the first 6 months was incredible, it was great, and then the next one was 6 months one day. Well, what about this?
Yeah.
What about this? And what about this? And you're like, listen, loose skin, not a big deal. It's gonna be fine. And then you realize it is a problem mentally for a lot of people, and whether it's a physical problem or a mental problem, it doesn't matter. And so when I started looking into kind of the minimally invasive skin tightening procedures, and I had sent this person, to a plastic surgeon back in the day, and she got like a quote for $50,000. And there's no way she was going to be able to do that. So it's like, okay, what else can we do? This is a problem. And this is a reason. The most common question that we get before surgery,
yes,
is what about my loose skin?
Yes.
You don't even have any of it, but that's the most common. So, where I once kind of ignored it and played it off, now we just address it full on. So we also have a very talented plastic surgeon who can do all these in our surgery center. And the pricing is much more affordable. We have the minimally invasive technologies that we do for skin tightening that we do in the office. And then you can address kind of all of the areas, with the jowling and the necks and the loose skin on the abdomen and the thighs, everybody. And that's the rewarding part of it. You're like, okay, you've done great, you got skin. Now it's the fun part. And so I tell people not to be afraid of the loose skin. It's something that can happen. You don't know who. It really depends on your genetics. So the example I kind of use on that one is you got maybe say it's like one woman who's had one baby and has terrible stretch marks. And you have this woman over here who's had 5 babies and has 0 stretch marks.
Yeah.
What's the difference? Well, the difference is the genetics and the genetic makeup of what's in their skin. How much collagen, how much elastin. That's the difference. So that's when people go, well, am I going to have loose skin or not? I don't even answer that question anymore.
Right.
Because I'm wrong half the time.
Yeah.
You don't know. So you just say, we will deal with it when we get there. We got to lose the weight first. We got to get healthy first. And then we can enter the fun part if you have it and if it bothers you. If it doesn't bother you, you don't need to deal with it. If it bothers you, we deal with it. We have options. And so that's where very early on, I think it was 2018, started our plastics and cosmetic thing to incorporate, okay, how do we address these issues? The patients we know we're going to have, we know they're going to experience. We want to be able to take care of them with people who are, know how we like to take care of our patients and our bariatric surgery patients, and be the same, and not just, go off somewhere where they're going to get a different kind of experience. So we've kind of brought that in-house too. And I know you have recently as well.
Yeah. No, I think what you're saying is so real. It's not like you run a marathon, but you only do 26 of the 26.2 miles. Like, finish it off if that's what you need in one. And the results are amazing. And yeah, everybody's different. I love the med spa aspect. I love Radiance by Roller. If Dr. Kristen is still on, I also really admire her and all the things that she does. And I'm looking at her social and I'm like, oh, okay, still a few things here and there and all the good stuff. But yeah, it's a true comprehensive experience. That's what we all want. A one-stop shop, people and trust, and you don't have to look anywhere else. So I think, the big thing is, what's next? What are you going to do next? You build a surgery center, you have all these multidisciplines that are right there under one roof. What are you going to do? Tell me so I can follow you very closely.
I don't know. I haven't come up with it yet. We just got one kid and finished her first year of college, and we'll probably doing a lot of traveling, watching her play basketball next year. But I don't know what's on the horizon. I think it's going to be, how do we make surgery even better? How do we, I think with telemedicine starting to get to be a little more accessible with the insurance companies and things like that, Well, I'll tell you this. Probably my next goal is really working with the insurance companies to allow us to do more and more in the surgery center. Um, because I think right now they're going to be the roadblock to getting a lot of this done. And, once they realize there's plenty of data to show that it's safe, to show it's more affordable for the patients, and the outcomes are just as good. I think we'll be in a good spot. So I think we're probably maybe a year away from that.
Yeah.
But that's what we're working on now. In fact, one of the things that we just did in Arkansas and just got passed as a state law was starting January 1 of 2026. There's mandated employer coverage for weight loss surgery from all employers.
Wow.
So, yeah. So that was a big win for the bariatric surgeons in Arkansas. So I think they've done that in Louisiana, but that was able to get passed this summer. We have an amazing governor, Sarah Sanders, Sarah Huckabee Sanders, and she's been awesome for our state and got that signed into law. So that's a big deal for the people in Arkansas to know that. Now, it doesn't apply to our exchange plans, but employers have to cover weight loss surgery starting 2026.
Wow. Florida's very, 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 very far behind. Blue Cross Blue Shield largely excludes it, almost exclusively excludes it. And it's I got a lot of battles to fight here, but that's it. I think you're right. It's just keep on having the conversations, getting more people to realize that this is the most effective tool that exists to lose weight and to keep it off. It's safe. It can be done in a beautiful surgery center with the most amazing experience, with the most incredible skilled team. And you have a lot of fans down here. A lot of people are saying that they love you and your team, and and I think that you guys are awesome too. I love learning from you, and I love our friendship. And let's do it, Josh. Let's keep going and building. And who knows? Maybe we'll scale this thing into a franchise together. You never know.
You never know. We could build the empire.
Let's do it.
Well, great. I
Fantastic.
appreciate the time. We'll do this next time on our page and just keep going and keep. So don't, if you're out there and you got questions, just message us, and so we can incorporate into the next one. But this has been fun. I appreciate our friendship as well, and I'm glad I got somebody to fight the fight with me. So
Let's do it.
good.
Well,
All
thank
right.
you, everybody. We'll see you guys next time. All
Bye.
right. Good night.